hiding the meeting controls. Thank you, everyone. So this is our final steering group presentation for the Chronic Pain Project. It's been a really interesting and impactful project. And thank you to the research team, Professor Fiona Blythe, Pippi Walker and Professor Andrew Wilson. And thank you also to you, our project steering committee, who provide invaluable feedback and insight into the project over the last couple of years. I want to take you through the journey of the Chronic Pain Project. I also thought this would be useful to the Prevention Centre representatives that we have online today. So as you know, the project was announced in 2018 as part of the MRFF funded Partnership Centre projects. At the time, codeine was being upscheduled and Pain Australia was lobbying about the need for opioid alternatives for people living with pain and how better to manage pain so that it does not become chronic and disabling. So the Department of Health realised that we needed greater understanding of what primary health networks were doing in this space, and perhaps there were evidence-based initiatives that could be scaled up. So the overall objectives of the Chronic Pain Project were firstly to synthesise knowledge about the secondary prevention and management of chronic pain, and secondly to improve knowledge sharing and knowledge use among primary health networks about options to address the secondary prevention and management of chronic pain in primary care. So we have had a high level of engagement with primary health networks. We've consulted with executive level staff and program leaders from all primary health networks, apart from one in metropolitan Victoria. So the Chronic Pain Project has provided opportunities for learning and engagement. For us, the research team, it's provided opportunities to understand the key issues, priorities and constraints for decision makers in primary health networks related to the secondary prevention and management of chronic pain. And for the primary health networks, it's created opportunities to understand the problem of chronic pain and to discuss options to address the problem. So looking at the research methods, this project comprised mixed methodologies. I'll go through the methods and later in the presentation, I will highlight the knowledge mobilisation activities of the project. So this slide provides an overview of our project. I'll go into the methods in more detail in subsequent slides. The project has been separated into 3 different focus areas for our work. The direction of the project has really been informed by our research findings and the needs of PHNs along the way. And I think this has been one of the enablers of success of this project, the emergent methodology and the responding to PHN's needs. So looking at phase 1, we reviewed the PHN needs assessments to understand their priorities and health and service needs. We consulted with PHNs via telephone interviews and online surveys. We held a workshop where we presented the findings from the consultations, and we also discussed opportunities for improving the management of chronic pain. In phase 2, we conducted a rapid evidence review of the peer review literature and also the grey literature. So most of the review related to the secondary prevention of chronic pain. However, we found that there was limited evidence in this area. So we supplemented that by looking at the evidence related to the management of chronic pain, initiatives that might have the potential to be adapted to the subacute pain population. And we also held a deliberative dialogue with PHNs informed by the rapid review, which was pre-circulated prior to the dialogue. And in phase 3, we have conducted an eDelphi survey of experts to establish consensus on the key elements and enablers to implementation of community-based pain programs. We've also conducted an online PHN survey about community-based pain programs to identify the existing program models commissioned by PHNs. So just going through some of the key findings of the project and looking at phase 1. So chronic pain was identified as a health or service need by approximately half of PHNs. And all states and territories in Australia, apart from Northern Territory, identified chronic pain as a need in at least one PHN. Chronic pain was reported as a priority by 9 out of 25 PHN and the WA PHN Alliance. And all states and territories in Australia, apart from Northern Territory and Tasmania, identified chronic pain as a priority in at least one PHN. And we also found that metropolitan PHNs were more likely to identify chronic pain as a priority. So looking now at the key issues related to chronic pain and service needs highlighted by PHNs. Firstly, they've identified a high prevalence and a high burden of disease related to chronic pain, particularly arthritis and back pain. They also identified poor access to specialist pain clinics with long wait lists, and this was compounded by limited reach to regional and remote areas. And also there was a need for better management of chronic pain in primary care, using a multidisciplinary approach. And there was also a need for greater education and training for primary care providers relating to chronic pain management, and particularly non-pharmacological pain management. They also identified poor access to community-based programs or services, and poor access to allied health providers due to workforce shortages, particularly in regional areas, and also the cost barriers. High opioid prescribing, especially in regional areas, and the need for greater education and training around that. For example, de-prescribing of opioids and non-initiation of opioids. And poor understanding of chronic pain and effective use of medicines amongst consumers and the general community. And the need for better integration between secondary and primary care related to pain management. So for example, in the pre and post surgery setting. They also identified a lack of knowledge amongst primary care providers about the secondary prevention of chronic pain and the need for greater education in this area. And healthcare system related barriers were also identified, and that included Medicare reimbursement limitations. For example, there's a lack of Medicare reimbursement for chronic pain programs and inadequate reimbursement for allied health. So why was chronic pain not identified as a need or a priority in some PHNs? Well, there were three main reasons for this that we found and that were reported in the telephone interviews and the online surveys. So the first one was competing priorities, for example, diabetes and cardiovascular disease. The second one was chronic pain was often embedded in other conditions and issues, for example, musculoskeletal conditions, chronic disease, mental health and AOD issues. And thirdly, a lack of quality local data about health and service needs related to chronic pain and opioid prescribing. And this was compounded by chronic pain not being seen as a disease in data collection, for example, in the practice data that was collected and in other data collected. So as you know, chronic pain has been classified as a disease in itself through the World Health Organization. And our analysis indicated a widespread lack of recognition of this by PHNs. In this project, we developed a framework of options to address the management and secondary prevention of chronic pain for PHN decision makers, and this was updated throughout the project. It was informed by evidence-based initiatives that we identified in the rapid review, and it was also informed by the types of chronic pain initiatives currently implemented by PHNs that were identified in the consultations. So this is what it looked like. I won't go into the details. I'll just say that the framework was based on 3 goals, and that was adapted from the goals of the National Pain Strategy, and it was aligned to PHN's remit. So we mapped out PHN chronic pain initiatives throughout the project based on this framework of options. And we found that the most common types of PHN chronic pain initiatives were face-to-face pain education and training sessions for primary care providers about chronic pain management. And the second one we found was, most common, was development of relevant pain pathways in health pathways. So PHNs were less likely to be implementing chronic pain initiatives for consumers. There was also a number of other gaps which we identified, in which we found that was only a small number or no PHN initiatives in that space. So I'll go through these. So these were the gaps. Consumer and health professional initiatives related to the secondary prevention of chronic pain. Post-surgery transitions of care. Consumer initiatives that link secondary to primary care, for example, in that surgical setting. Opioid education initiatives for both consumers and health professionals. Digitally delivered initiatives for both consumers and health professionals. So that's excluding health pathways. And consumer and health professional initiatives related to specific populations, for example, Aboriginal and Torres Strait Islander peoples. And face-to-face community and consumer pain programs and support groups. So there was only 6 pain programs in the beginning part of our project, and by the end there were 8 consumer pain programs, but there could be more. And we found only 1 PHN was implementing a support group related to chronic pain. So our directive from Greg Hunt was to find any evidence-based initiatives currently implemented in PHNs that could be scaled up. And we found 2 major initiatives. Firstly, our Project Echo. You're probably all familiar with that. To just explain, it uses like a hub and spoke model to promote knowledge exchange. So it's really creating a community of practice between a hub, which is usually a multidisciplinary panel of health professionals, often sitting in a tertiary setting, and the spokes, which are the primary care providers. And we're currently evaluating this type of program, Project Echo for persistent pain in Western Victoria PHN. And the second major initiative that we found was community-based pain programs. And as I said, they're now being implemented in 8 PHNs. So we decided to focus a little bit more on community-based pain programs in phase 3 to provide more guidance for PHNs and to understand the different PHN models. So as I mentioned, we conducted an eDelphi survey of experts, and these were the key elements and these were the key enablers that we found, and there were subcategories of these. I won't go into going through the details of these now. And also, as I mentioned, we conducted a PHN survey to understand whether the PHN pain programs were addressing these elements and implementation enablers. And to give us more details of each of the pain programs being implemented by PHNs, particularly things like costs, which will be really important for other PHNs to look at. So we held a PHN webinar yesterday to present the findings. and for a few PHNs to present their different models. And we're aiming to develop a resource in partnership with Pain Australia and New South Wales ACI in the next few months, which will be disseminated to PHNs. And we're also hoping to adapt this resource for health professionals and consumers to be disseminated through Pain Australia and ACI websites. So through the different methodologies of the project, we were also able to highlight some of the enablers to implementation of PHN chronic pain projects identified by PHN. So not looking at specific initiatives, we're looking more at overall enablers. So in other words, what has helped PHNs to get their chronic pain initiatives up and to help them implement and sustain the initiative. So firstly, very important that chronic pain was identified as an issue, need or priority in PHN needs assessments. Also local champions like Joyce, they could be clinical or non-clinical within or outside of PHNs. Also partnerships with local health districts and local hospital networks and other government and non-government agencies. And Health Pathways is a good example of partnerships. Government directives, policy windows and media coverage were also important enablers. For example, as I mentioned, the upscheduling of codeine. Also, if the initiative had been implemented by another PHN and the PHN was aware of this. And also evaluation of programs. If the program had been evaluated, and then it provided the rationale for continuing investment. Linking with existing services to share the resource burden. And skilled workforce. We found that a lack of skilled workforce to deliver initiatives in rural areas can be a barrier. And there's a need for local upskilling of health professionals. And for example, this is Michael Nicholas's work at the Pain Management Research Institute. And lastly, PHN executive and program leader buy-in and committed adequate funding for the initiative. So just some reflections on the overall challenges and constraints identified by primary health networks. We found differences across PHNs in terms of local needs, their expertise and leadership. We found competing needs and priorities within individual PHNs with overall limited funding and resources. There was a lack of quality local data about health and service needs. There was a lack of a formal mechanism for communication and collaboration. Unlike the old Medicare Alliance, there's not a formal body for PHNs. There's also scarcity of resources and expertise relating to monitoring and evaluation, with evaluation reports often not being publicly available. And PHNs also have relatively limited experience of commissioning services. There were healthcare system related barriers, as I mentioned. Example relating to Medicare. There were fragmented pools of funding in PHNs, constraining the effective implementation, sustainability and scale up. And there was a historic and ongoing focus on general practitioners with inadequate focus on allied health and community pharmacists. So some of the solutions proposed by PHNs to address some of the challenges and constraints included the following. The need for greater opportunities for communication across PHNs. To consider adapting initiatives rather than developing new initiatives that are currently implemented in PHNs to reduce the resource burden. The need for PHNs to consider funding streams for chronic pain initiatives outside their limited flexible funding pool. So for example, mental health and alcohol and other drug drugs funding, and the need to share resources and expertise through external partnerships with local health districts, local health networks and local hospital networks, state and territory government agencies and non-government organisations. So looking now at the impact of the project, really impact has been the main focus for us and our motivation in this project. So firstly, looking at the impact activities. So looking firstly at the impact activities involving PHNs, the workshop, as I mentioned, the deliberative dialogue. We also ran an online presentation and discussion about COVID-19 adaptations to community-based pain programs. As I mentioned, we held the PHN webinar yesterday about pain programs. We created a number of resources. We had email consultation throughout the project. And we offered in-kind advice related to evaluation and implementation to a few PHNs. And these are some of our information resources. So looking at the impact activities, it involves stakeholders. We engaged the Electronic Persistent Pain Outcomes Collaboration to deliver a presentation to PHNs. We engaged NPS Medicine-Wise to deliver a presentation to primary health networks. We engaged New South Wales ACI and Pain Australia, as I mentioned, to collaborate to develop a resource, which we'll be looking at doing in the early next year about community-based pain programs. And we also presented to the Therapeutic Goods Administration about current PHN chronic pain initiatives and possible synergies with the TGA work. And we engaged the TGA to develop opioids and pain medicine resources for primary health networks. And we offered in-kind evaluation advice to a commissioned agency in the Gold Coast for their pain program, the subacute pain program. And as you know, we have had regular meetings and updates to the steering group, and we've also published e-newsletter articles and a pain podcast, Fiona and the Prevention Centre. And I was also involved in the consultation on preventative health in primary healthcare in Australia in September. So looking at the impact activities that involved researchers, peer review publications. We've had one published, one's in the pipeline with just revisions, and we've got 2 more that we're writing. We've been involved in conferences, presentations and posters. We formed a partnership with another Prevention Centre research team to write a paper. And we've supervised 2 capstone Masters of Public Health students. So in terms of grants, we were awarded as part of a consortium by the Department of Health, Commonwealth Government, a grant about health professional pain management education. And really the Menzies project activities are really an extension of the chronic pain engagement, chronic pain project, our engagement with PHNs, and also our engagement with NPS Medicine-Wise. And we've also, as I mentioned, doing the evaluation of Project ECHO in Western Victoria PHN. And we've recently put in a grant application, an MRF, primary care research grant application about Project ECHO and involving PHNs. So fingers crossed about that. So what does this all mean? What has been the impact of the chronic pain project? Well, we won't ever know all the ripples, the linkages, relationships, feedback loops and interactions amongst the system's parts. We also haven't comprehensively consulted with PHNs and stakeholders and researchers to explore the impact of our project. However, we do have some examples. So how have we influenced understanding of the problem or knowledge of options to address the problem? So looking at the workshop that we held, all participants said that it improved their knowledge of chronic pain initiatives being implemented by other PHNs. And looking at the deliberative dialogue, the vast majority of participants reported that it had improved their knowledge of the problem and options to address the problem, and also implementation considerations. And it also helped them to identify what may be feasible for their PHN to implement. So just a couple of quotes. Attending the workshops brought the importance of early intervention of acute and subacute pain to the table, which has ensured that we address this need in our ongoing conversations with the LHD, GPs and consumers. Yes, it improved our knowledge and we have more confidence to speak with local health networks on the subject. So how have we contributed to greater collaboration and knowledge sharing to understand and improve the problem? All participants from the workshop and deliberative dialogue said it helped foster communication and collaboration between primary health networks. It's also led to the development of a primary health network only SharePoint related to chronic pain, a community of practice. This was established in December 2019 and it's been led by 4 PHNs. And just a couple of quotes. Thank you. This is one of the few opportunities I have to talk to other PHNs about a problem that affects us all, and I really value it. And another quote, we connected with a Melbourne PHN to discuss their potential implementation of a chronic pain initiative and share our learnings. So how have we influenced any decisions or discussions to support policy and programs? So looking firstly at secondary prevention, our work led to the development of a tender by Eastern Melbourne Primary Health Network to address subacute pain. And the tender described the Prevention Centre project and our principles and referred to many of our recommendations. Unfortunately, the tender respondents were not suitable. So we're now brainstorming at the moment another project related to the secondary prevention of chronic pain. Also, it had a contribution to the Gold Coast Primary Health Network commissioning of a pain program for people with subacute pain. And as part of the business case, this project was referred to in the business case. It also contributed to Southwest Sydney Primary Health Network implementing a pain management CPD event from acute to chronic pain, attended by 29 PHNs. And we've also had an influence along with New South Wales ACI, which has offered enormous support for New South Wales PHNs for new community-based pain programs for chronic pain. So the new ones that have been developed are based in the PM Blue Mountains, Northern Territory and Murrumbidgee are in the planning phase. And Adelaide PHN has developed, it's a short-term project for like a pain, but it is a pain program to support refugees and other people newly arrived from overseas. Just a couple of quotes. Oh, the first one was the business case put to the Gold Coast PHN from PainWise. Current research by the Australian Prevention Partnership Centre have recommended primary care healthcare identifies and manages subacute care patients to reduce healthcare burden of chronic pain. And this is another quote from the Adelaide PHN. The project gave us some insight to follow up with ACI about the needs of culturally and linguistically diverse people, and then to proceed to develop and implement the Called Pain project. So other ways that we have influenced decisions or discussions. We've had evaluation impacts. In terms of EPOC, we've increased participation in EPOC. We've increased data and timeliness of reports. It's also led to the commissioning, as I said, of the evaluation in Western Vic PHN. And I think that by offering in-kind evaluations advice, it influenced their thinking about evaluation and contributed to the commissioning of that evaluation. So looking at opioids, as I mentioned, we engaged the TGA to develop resources for PHNs that we could disseminate through our networks. Also Southwest Sydney PHN, their AOD network, led a discussion on chronic pain. And just a couple of quotes from EPOC researchers. We've had several PHN EPOC inquiries since the PHN workshop, and 3 more PHNs are now in the process of joining EPOC. And the TGA, thank you for reaching out to us in advance of your contacting PHNs. And this is a quote from a PHN who received the TGA resources. I'm ready to put these immediately in the next newsletter, perhaps do a presentation to the PHN. So just a couple more ways we've had impact. The Tasmanian Health Service used the chronic pain resources information resource that we created to determine appropriateness for their patients and colleagues. And the Australian Pain Society lists our chronic pain project resources on their website. And this is just a quote from the PHN in Tasmania. I've recently been given a copy of the chronic pain resources released in March 2019. This is great. I was thrilled to see it. I'm currently project managing on service delivery for pain management in Tasmania, and your extremely thorough publication has saved me an enormous amount of work. So that's pretty good feedback. So just in the interest of time, just finally, just going through some enablers of the success of the project. I think probably the most important enabler is that we've invested in relationships. We've invested in relationships with PHNs throughout the project. We've engaged champions within the PHNs. We've framed the problem and possible solutions using evidence. We've used deliberative processes. We've responded to need using an emergent methodology. We've provided in-kind support. We have a large and well-connected steering group, thank you. We've created partnerships, as I've mentioned, and we have had an enabling context. For example, the Pain Australia Action Plan, the opioid crisis, and New South Wales ACI work. And we've had support from the Prevention Centre. So this isn't just about funding, it's also about their communication through the website and help from the team. It's also about a way of thinking about research into practice and policy and co-production and systems thinking. So the next phase of activities building on our work in the chronic pain project, well, it officially ends on the 31st of December this year. And as I mentioned, we'll just early next year, we will be developing a resource with Pain Australia and ACI. And we will be finishing off the evaluation for Western Vic PHN. And also we'll be involved in, for the next few years, the Pain Management Education Grant, where we'll be piloting Project Echo in one PHN. We haven't selected them yet. And strengthening NPS Medicine-Wise initiatives. And the MRFF grant, well, who knows? But we do have lots of other ideas about how we will build on our work in this project and build on our engagement with PHNs. So for your interest, I will circulate this to you separately, but we do have a list of our reports and publications and things. So thank you to the Australian Prevention Partnership Centre. And thank you. Any comments?